Thank you so much. I appreciate it. And I, first of all, apologize for not being able to come over. I just was talking with Mark and Carlo about the fact that I have not actually been outside the United States since the COVID epidemic. So I took a hit there and a couple of other places. So anyhow, I'm hoping to get back to Europe maybe by the end of this year. But I apologize for not being able to be there. Brussels is one of my favorite spots. Carlo had corresponded with me much earlier and asked that I talk about atrial fibrillation ablation and how it had been a triumph of modern medicine. And so we'll start from that spot. And I thought I'd look at it as I always try to look at things a little bit differently each time I talk about this. And in this case, I think it's important to look at the different approaches, the different way atrial fibrillation has been approached from an interventional standpoint, because there are basically two ways of approaching it. One is to try to isolate things, either the AFib itself or the triggers for it, and another is to ablate it. So it interestingly enough fell into two different eras, because the very first operation or intervention, I should say, it fell into two eras. Interestingly enough, it's a little bit surprising. The very first thing that was done for atrial fibrillation from an interventional standpoint was a His bundle ablation. And that was done first by Dr. Will Seeley in 1973, which has been a long time ago. And obviously in that situation, we didn't know anything about atrial fibrillation. I was with Dr. Seeley at the time. We didn't know anything about atrial fibrillation in terms of how to even think about intervening in it. So that's what the wavy lines are up here rather than the micro-reentrant circuits. But the idea was that if it was absolutely uncontrollable and couldn't be treated at all, we did elective His bundle ablations and then put a permanent pacemaker in the ventricle. The His bundle ablation, of course, isolated or confined the atrial fibrillation to the chambers and allowed us to the atrial chambers and allowed us to control the ventricular rates and function. It occurred to me when we were doing this in the OR one day, these were open heart surgical procedures, by the way, and we'd go in and try to map and find where the His bundle was and then ablate it, usually with cryosurgery. But it occurred to me one day that since the SA node is in the right atrium and the AV node is in the septum, that maybe we could isolate the left atrium and confine the arrhythmia to the left atrium. It was really developed for automatic atrial tachycardias that we couldn't map in the operating room because general anesthesia suppressed them. But in developing that procedure for automatic left atrial tachycardias, we found that that isolating the left atrium, which we described in 1980, also could isolate atrial fibrillation to the left atrium. And here's the evidence for that from an experimental animal. And you can see that the other three chambers of the heart are in sinus rhythm, but the left atrium is fibrillating. Now, we never used this operation to treat atrial fibrillation because it didn't take away the risk of systemic thromboembolism, and it didn't take away the problem of not having a left atrial function available. However, Vigano in Italy did over 200 cases like this and had very reasonable results for atrial fibrillation from a symptomatic standpoint. The next thing that was introduced was catheter fulguration of the His bundle by Mel Scheinman, and at that time Fred Moratti was with him out in San Francisco. This was in 1981-82, in which they put 300 joules retrograde through a His bundle catheter and could block the His bundle. So that we never did another surgical procedure for it because as traumatic as fulguration was, it was better than having to do surgery on them. In 1983 or so, we also developed a right atrial isolation procedure for right atrial tachycardias. The right atrial automatic tachycardias are usually multifocal in origin, as opposed to the left atrial tachycardias, which are usually unifocal. But the trick to isolate was to isolate as much of the right atrium as we possibly could without damaging the root between the SA node and the AV node, and require a pacemaker. In 1985, our great friend Gerard Guiraudon, originally from Paris, of course, so Salpêtrière, but by this time in 85, he was in London, Ontario with George Klein. And he took these two procedures, the left atrial isolation procedure and the right atrial isolation procedure, and realized that if you did both of them, that you could leave this corridor between the SA node and the AV node and confine the atrial fibrillation to the two atria. And they didn't always fibrillate when you separated them like that, but they usually did. But the point was that this would avoid the need for a pacemaker. The physiology is the same as ablating the hip bundle, putting a pacemaker in, but it's nice to avoid the pacemaker if you can. Now, the thing that all of these procedures had in common, from the very first one in 73 to 1985, Gerard's Carter procedure, was that they were all isolation procedures for AFib. In other words, they didn't make any attempt to ablate the atrial fibrillation. In fact, they didn't ablate atrial fibrillation. So the second step in the interventional process was to develop a procedure that would actually ablate the atrial fibrillation rather than just isolate it to one area of the heart. And the first step for us in that was in 1980, we developed an animal model of atrial fibrillation that we thought was a bit more like the clinical situation might be. And to do that, we did a sterile left thoracotomy in dogs and put a purse string suture in the left superior pulmonary vein just outside the pericardial reflection. And the reason for putting it outside the pericardial reflection is I didn't want to do anything that would cause scar inside the pericardium or that would cause scar in the left atrium, because that could alter the natural status of the atrial fib. So we passed a biopsy needle across the mitral valve and started clipping the cords until the left atrial pressure rose from around 2 to around 20. We had a Millar catheter in the left atrium. And that served as our model, our experimental model of atrial fibrillation for the next 40 years. Once we were able to have a good model of atrial fib, John Bueno and Rick Schuessler in our lab took advantage of some of the things Moritz Alessi and Hein Vellens had been doing, and took it another step by making some form-fitting electrodes that fit the inside of the right and left atria of dogs and embedded multiple bipolar electrodes on the surfaces of those moles. And that allowed us to do three-dimensional mapping of arrhythmias in animals experimentally. Now, we got very lucky at this point in time because at that time, there was no way to recreate a three-dimensional image of the left atrium. There's a guy named Mike Vanier at the Mallinckrodt Institute of Radiology in St. Louis actually had been doing that with every organ in the body. And so I went to him one day. I said, do you think you could give a three-dimensional image of the heart? He said, well, it would have to be gated by the EKG. And I said, I understand that, but I don't know how to do that. And so what he did is he did gated MRI scans, and for the first time was able to create three-dimensional images of the heart, and in this case, the atria. And these slices were 1 centimeter apart, so that's why you see some of the rough edges. But nevertheless, having both the three-dimensional anatomy and the ability to map in that atrium the three-dimensional electrophysiology with all these electrodes, it gave us the ability to actually see what was going on in atrial fibrillation for the first time and atrial flutter. these are individual shots from a video, which I don't have time to show you, but these are individual shots from a video that were taken of atrial flutter in this case. And this was in 1985. So this gave us the tool to really study this disease in a way that perhaps hadn't been studied before from an anatomic electrophysiologic standpoint. At the same time, Bueno and Schuster developed these silastic epicardial electrode arrays that I was able to put on patients in the operating room with IRB approval to cover all the surfaces of the atria. And who are we mapping? Well, we did about 150 WPW operations a year at that time, and about 30% of them had atrial fib. So we went through the IRB and got approval to map the atrial fib in those patients. So we would map the atrial fib for maybe 2 or 3 seconds, and then spend 2 or 3 weeks trying to figure out what we had. But that's how the original mapping started. Early on, we developed the erroneous concept of atrial fib as being primarily a big reentrant loop around the pulmonary veins and left atrial appendage on the left, and another one around the SVC and IVC on the right, is the emphasized in capital letters erroneous concept. But we didn't know that then. So we used this as a basis for trying pulmonary vein isolation. Pulmonary vein isolation puts the lesion out to the lateral wall of the atrium, plus a septal lesion. We tried all kinds of things by trial and error, and none of them worked except this one. And that was one that a lesion that started at the left side of the mitral annulus, came up across the atrium between the pulmonary veins and the left atrial orifice, across the atrial septum, sparing the AV node, of course, and then on across between the SVC and the IVC on the right, and down to the lateral side of the tricuspid valve. That one worked every time. We called it the atrial transection procedure, and these are the results we got when we did that in our animal model in the lab. So after a long story, and you can read about this in the literature, it's all over the place, about the airline pilot from Cyprus who pushed us into doing this with IRB approval, we did an atrial transection procedure in 1986. It worked very well for about 5 months, and there's a long story behind this, which is probably worth a 10-minute read sometime. It's called the first Maze procedure, but nevertheless, the fact is that at 5 months after surgery, the pilot developed pericarditis from viral pericarditis and went back into atrial fib. But it at least told us that there was a chance we had. In the meantime, we'd been doing a lot of mapping and realized that we knew, we finally figured out what was going on in atrial fibrillation, figured out a way to treat it with the Maze procedure, which I won't bore you with because I know you've heard it 1,000 times, and then performed the first Maze procedure in 1987. And so, as a matter of fact, I don't know what the day of the month is, but 25th of September will be the 37th anniversary. Anyhow, we did the first Maze procedure, and that patient did well. And the thing I remember most about that patient is that at his 3-month visit, Moritz Alessi happened to be visiting our electrophysiologist at WashU in St. Louis. And Bruce Lindsay called and said, Moritz Alessi's here today. And I said, oh, I didn't know that. You should have told me earlier. And he said, well, I'm with him now. He said, I'm downstairs now. He said, where are you? I said, up at the clinic. I said, I'm seeing Mr. So-and-so. And he said, well, let me bring him up there and let him see him. So Moritz came up and actually took the pulse of the first Maze patient we ever did. And I said, what do you think about it? He said, yeah, he's a sinus rhythm. No big deal. I said, well, he had an operation for atrial fib 3 months ago. And he said, an operation. So anyhow, that was one of my my finest moments when I was able to show that to Moritz and Leslie, because I've often said I thought Moritz had forgotten more about atrial fibrillation than the rest of us will ever know. Nevertheless, this is what the Maze 1 looked like. And it really fixed the atrial fib quite well. But after we had done about several patients, maybe 30 patients or so, we realized that we had a problem with this operation. The first problem was that some of these people were real active athletes, and they couldn't generate a sinus tachycardia. So if you think about it, when you start running, so you begin exercise here, your heart rate goes up, and then it levels off. Mine would level off a long time before that, but it levels off, let's say, at 135 or so. And then you stop exercise, and it takes a few minutes to get back down to its baseline value. But when these people, after the Maze 1 procedure exercised, they started increasing their rate normally until it got to about 100, and then it leveled off. And no matter how hard they exercised, they could not get their heart rate above 100. And the other strange thing is that when they stopped exercising, they stayed at that heart rate of 100 for several minutes, and then caught the slope of this on the way down. So you can see that everything was working perfectly well, except we had knocked out the sinus tachycardia site. And I didn't even know about the sinus tachycardia site then, but John Bueno fortunately did, because he had done the experiment in dogs several years before and showed that they had a sinus tachycardia. It's called the atrial pacemaker complex. So we did a study in humans, found they have exactly the same thing. And I realized immediately that I said, well, I got a lot of lesions through the sinus tachycardia site. And that was the problem. The sinus tachycardia site's a small area immediately anterior to the SVC junction with the right atrium. And if you start putting lesions through there, you're going to have patients who can't generate a normal chronotropic response to exercise. Or to freight. So the second problem we had with this lesion pattern, the Maze 1, was that we noted when patients came back, Bruce Lindsay studied all these patients in the lab, did full-blown EP studies on them at 6 months. And he was finding in about 30% of the patients that the right atrium and right ventricle were in AV synchrony. But the left atrium sometimes took 150 milliseconds to activate completely. And that's about how long it took the impulse to get through the AV node to the left ventricle. So the left atrium and left ventricle ended up pumping at the same time. So it looked like there was no left atrial transport function. So Bruce put a left atrial pacing catheter in, and as soon as he started pacing the left atrium, everything was fine. It was perfectly AV sequential, good function of the left atrium and so on. So we realized that what we created with this operation was an interatrial conduction block, and we knew exactly where it was. It was because we had transected Bachman's bundle in more than one place with these lesions. Now, you might get away with that without being too much trouble if you don't have these lesions back here to prevent perimitral flutter. But we had these lesions, so it took a long time for the impulse to get through the septum and across to the lateral left atrium. So our approach to this seemed to be fairly obvious. We moved those lesions that did all these bad things back. We dropped them down behind the Bachman's bundle and sinus tachycardia site and so forth. This was the Maze 2 procedure. And after about a dozen cases, we learned that there was a real problem. Well, after one case, we learned there was a problem, but after several cases, we learned there was a real problem with the Maze 2. And that is that we had 3 lesions coming up into the SVC. Well, we actually had 2 lesions, but we had to divide the SVC in order to see the inside of the left atrium well. And it was a technically very difficult operation. I ended up spending about as much time patching and repairing the SVC in these patients as I did doing the actual procedure. So I finally said, I'm not doing any more of these things. They're too hard to do. So the way we approached that was to move those lesions, primarily the septal lesion, even further back. In the meantime, radiofrequency catheter ablation had been introduced. And so the electrophysiologist started doing RF ablation of the His bundle instead of catheter pulsation of the His bundle. Notice these are both isolation procedures. They do not cure atrial fibrillation. These do, but you pay a price. So we went to the Maze 3 procedure in 1992 and never used anything else after that. The Maze 3 procedure, the septal lesion was posterior to the IVC orifice, and box lesion was placed around the coronary veins, left atrial appendage was taken, and so on. Nothing else has really changed from the two. This is a very easy operation to do compared to others, and most surgeons who do this routinely think it's a very easy operation, although it's always seemed to look difficult for non-surgeons. Well, then the third step was to ablate AF with less invasiveness. And in 1996, we did the first minimally invasive cryo-Maze 3 procedure. Now, all three of these procedures were what we call cut and sew Maze procedures. They were done with a scalpel and scissors and suturing up the lesions and so on. We realized that was not feasible through a small incision in the chest. And in the mid-90s, everybody was trying to do everything more minimally invasively. So we'd used cryoprobes since for over 20 years, 25 years. And so we needed a linear cryoprobe in order to do these lesions with cryosurgery rather than with cut and sew. We didn't change the lesion pattern. And one of the fallacies in what you see written a lot is that the term Maze 3 procedure is synonymous with the cut and sew Maze 3 procedure. It's not. I did more cryo Maze procedures than cut and sew, cryo Maze 3 procedures than cut and sew Maze 3s. NEVAD has done over 1,500 of them now. So you don't use a knife and scalpel and suture up the lesions and all that stuff with this. You just simply freeze the lesions. The problem in 1996 was that there was no linear cryoprobe available. So I took a probe that we'd had Frigitronics develop for us that was with a little 2 millimeter tip to treat AV node reentry back in the early 80s. And it had a long shaft on it that was insulated. So I just cut the insulation off of a couple of them and used those as linear cryoprobes. They worked very well. Fortunately, FDA didn't know about that, but eventually Cooper Surgical and then later, because I guess ATS Medical bought the cryo system, made some linear cryoprobes, and now we have two flexible, disposable, wonderful linear cryoprobes. One made by AtriCure, and one that's a nitrous oxide probe, and one made by Medtronic, which is an argon gas cryoprobe. But nevertheless, then we didn't have that. But we could do this quite in a straightforward manner by making a small mini thoracotomy in the fourth interspace anterolaterally on the right side and a groin incision. And we're able to do the right-sided lesions off pump through purse string sutures. And this is the linear cryoprobe. So we take an 11 knife blade, pop a hole here and put this in and lift up. And when you lift it up, that excluded the blood from the freeze surface on the endocardium of the atrium. So you could create very nice cryo lesions this way. This just shows one in the right atrium. So we would do these right atrial off-pump lesions during the rewarming phase after we'd cross-clamped and done the left-sided lesions. So we didn't add any pump time to the procedure. The left-sided lesions were done also fully with cryoprobes like this and so on. And this doesn't show them all, but it shows you how to make the box lesion, for example. And then when bipolar radiofrequency clamps became available in 2000, about 2002, Ralph Damiano described the Maze 4 procedure, where you used a combination of cryo, which is fairly slow, and bipolar radio frequency, which is fairly fast, and described as the Maze 4 procedure. This included isolating each pair of pulmonary veins individually with bipolar radio frequency clamps like this, and then creating roof and floor lesions to create your box. In the Maze 3, we created it this way, but it electrophysiologically, as you can see, is exactly the same. So there's really no electrophysiologic difference in the Maze 3 and the Maze 4. We sort of refer to it now as the Maze 3/4, but nevertheless, the Maze 3 to the Maze 4 had the advantage of being able to be performed more quickly. As another step along those lines, Pat McCarthy, my current partner in Chicago at Northwestern University, developed a way of doing all those left atrial lesions with three three-minute applications of cryo, one here, and one outside here. And then on the right side with three applications of 2-minute cryo lesions, 9 minutes to do the left-sided lesions, 6 minutes to do the right-sided lesions. So now it's not very onerous to add these to our concomitant procedures. Well, the results were reported by Ralph Damiano in 2003. Those results were all patients that I'd operated on in St. Louis prior to his arrival there. And they were 94% successful at 15 years. Now, in 2003, we didn't have loop recorders and Zio patches and so on. And so over the years, we've learned that the follow-up is probably about 10% higher than it actually was had we used modern day follow-up techniques. So we'll move that down to 84%. And if you draw a line directly between 100 and 84%, then I think that's a fair assessment of the results of the original Maze procedures that patients that we operated on. In 2017, Nevad reported his 5-year results, and the results were 90%. And in 2021, Damiano reported his 10-year results, and they were 89%. And they fall right on that green line that was established years ago. So I think this shows without any question precisely what the results are of open heart surgical Maze procedures, whether you do a cut and sew Maze 3, a minimally invasive, a Maze 4, a mini thoracotomy. If you use these lesion patterns, and you do them correctly for each lesion, this is what your results will be. Having said that, McCarthy, my partner, again, just recently looked at almost 80,000 Medicare patients and looked at the incidence of preoperative atrial fibrillation in those patients that we operate on. For example, it's about 20% of the patients we do CABG procedures on have pre-op AFib history. About 35% of AVRs and about 62 or 63%, 2/3 of mitral valve patients do. So pre-op atrial fibrillation, when we're doing our standard cadre of open heart operations, atrial fibrillation is a very common occurrence in those patients. And so that's why we thought after all these years that we now know how to fix it, that we should fix it. In the meantime, it's been shown by multiple people that the survival rate's improved, the stroke rate is pretty much taken away, and so on. But in that study, only 29% of the patients coming into the operating rooms in the United States, Medicare patients who had AFib, actually had an ablation in addition to their primary procedure. It was 38% rate for mitral valves and only a 16% rate for non-mitral patients. And this is after 30 years of being able to treat atrial fibrillation very well. It's after 20 years of knowing what the surgical results are in terms of long-term stroke and in terms of 10-year survival and so on. It's after receiving a Class 1A recommendation from every surgical and medical sets of guidelines in the world is still ignored. And the reasons for that have been given are multiple. This one always is interesting to me. But nevertheless, the most interesting ones are the lower two, where people actually believe that atrial fibrillation makes the AFib worse or that it doesn't work. And I'm not sure what planet they're on, but that's the thing we hear. The fourth step was catheter ablation for isolation of AF triggers. And this was done, of course, everybody's familiar with Hasegaer's work in pulmonary vein isolation. Again, this is an isolation procedure, it's not an ablation procedure. And it was recommended by Hasegaer himself for paroxysmal atrial fibrillation and not for anything else. So the efforts at doing actual catheter ablation procedures, well, as everybody knows, this took over. With actual catheter ablation procedures, started a bit later and has been directed towards substrate modifications. You all know. This is an article that I'm going to pretty much finish with, is by Roger Winkle, who most of you know, been in this business for a long time. And Roger reported on 5,200 personal patients over 16-year follow-up, divided them into paroxysmal persistent line, standing persistent, divided it into 3 different eras based on the availability of the most up-to-date catheter ablation techniques and equipment and so on. And what he found were these results for the catheter ablation of paroxysmal AFib at 16 years. 2 out of 3 of them are cured. Persistent, a little less than half. Long-standing persistent, about 1 out of 5. How do those numbers compare with midterm results? Well, his 9-year results, Winkle's 9-year results, 75%. The only other 9-year study was Takagawa's, also exactly 75%. His persistent AF patients at 5 years were 60%. The multi-center German study reported 56% at 5 years, 4% difference. And his results with long-standing persistent of 20% at 16 years, they were 45% at 5 years. And of course, everybody knows the Hamburg study was 45% at 5 years. So I think the fact that these numbers are absolutely identical at 5 years tells you, it makes the remaining portion of that curve of Winkle's, which is the only one we have out to that time, it makes those other curves, it validates them, I think. If you look at his overall results at 5 years, his overall, for all types of atrial fibrillation, all comers, was 65%. The Cabana trial was 64%. So I think we can believe this study in terms of its longevity. So we now know not only exactly what the Mays procedure does, but also what the catheter ablation does. And the attempts at actual catheter ablation, I guess the most famous one was the STAR 2 trial, in which pulmonary vein isolation was compared to isolation with ablation of cafe spots and pulmonary vein isolation with additional linear lesions, which is really difficult to do with a catheter. And it showed no difference at all. So no improvement, actually a little worse with cafe ablation and lines. And the reason for this is that cafe ablations don't have anything to do with the maintenance of atrial fibrillation. It has a great deal to do, I think, with the initiation. And there certainly can be triggers, but they can't sustain atrial fibrillation. And the problem here is that it's just, as Hasegaer himself said, it's very difficult to create a linear lesion with the tip of an 80 centimeter catheter. Another aspect that I think is worth mentioning, just brief, in the final two slides, is this cardio insight system. As many of you know, Mary Ehrlich and his colleagues at University of Vienna has written a lot about this, and he's worked with Nevad a lot. And three of us talked once about the fact that it's not possible to map atrial fibrillation multiple times in the same patient with any techniques that are invasive, including catheter ablation. But this gave the opportunity to map a patient who's in chronic, long-standing persistent atrial fibrillation multiple times and see if the drivers of atrial fibrillation, of the persistent atrial fibrillation, are stable in their location. Because what Hasegaer and people in Maastricht and Brussels, a lot of people as interventional electrophysiologists have tried to do various combinations where they're mapping in the operating room and identifying drivers and ablating those drivers and seeing what happens and so on and so forth. And by and large, it's been sort of a futile effort. So I think the reason for that is this. We decided to work with Merrick and have him, he looked at 12 patients. 10, I've got 10 patients rather, and mapped patient on day one. Nothing changed. No medicine changes. Nothing changed in the patient. Did them again more or less at day 10 to 12, and looked at the maps on the map of his atrial fibrillation on day one, the map of his atrial fibrillation on day 10. And it had the same number of drivers, but they'd all changed positions. And that was true in every single patient. Now, the implication here is that if you were trying to use these maps or even intraoperative maps, intraprocedural maps that are much more sophisticated than body surface mapping, as guides, you use those as guides in patients with persistent atrial fibrillation to tell you where to ablate. So I think we would ablate here probably on this patient. But if you happen to have mapped him 10 days later, you wouldn't have ablated him there. You'd have ablated him somewhere else. So that's true in every one of these things. So the lesson here is that atrial fibrillation is changing so much with time. And this can change in 5 minutes. It doesn't have to be 10 days. And it's the reason that we realized back in the mid 80s, we used to do this in the lab and try to chase these things. And you end up with lesions all over the heart that don't make any sense. And it didn't stop it. It just moved somewhere else. So if we saw a big reentry circuit or a hot area, we'd ablate it and it just moved down here. And so we realized that unlike WPW surgery, AV node reentry surgery, automatic atrial tachycardia surgery, non-ischemic VTAC surgery, ischemic VTAC surgery, unlike any of those things we had done before the Mays procedure, all of which had been map guided. You can't map guide persistent atrial fibrillation ablation. We couldn't then, and it's 40 years later now, and you still can't. Now, maybe it will be possible in the future. I'm sure there are a lot of electrophysiologists in the audience who won't agree with that. But as someone once said, and I mentioned hybrid procedures before I get to the end of that, hybrid procedures were introduced, and as people in this audience are quite familiar, led by the group in Maastricht and your group in Brussels. And I think this is the most key slide that's been published yet, showing that in general, hybrid procedures overall are better than multiple catheter ablations. So we know what the results of Mays procedures are. We know what the results of multiple catheter ablations are for long-standing persistent. We're just talking about long-standing persistent. And for long-standing persistent, the hybrid Mays, the hybrid procedures fall somewhere in between. Some people report at 60% and some at 80% at around 3 or 4 years. I think I'll just skip this. It allows 3 trial. And what we've learned from that trial and subsequent ones is that if you do nothing to atrial fib at the time of surgery, the survival rate is not particularly good. If you just clip the atrial appendage, it's better. If you just do node ablation, surgical ablation, it's better. But neither of those in isolation is as good as a combination of surgical ablation and left atrial appendage occlusion. So in summary, I think the Mays procedure was first performed 37 years ago this week. It's safe and effective for ablating concomitant AF during CABG and/or valve surgery, and it improves operative mortality, quality of life, long-term strokes, and survival. However, it's too invasive to be a first-line interventional therapy for patients with standalone atrial fib. Despite 1A classification guidelines in both specialties, the vast majority of concomitant AF is not ablated in patients today. Catheter isolation of the pulmonary veins, PVI, is the procedure choice for PAF, but attempts at the actual ablation of AFib with catheters has been disappointing in patients with non-PAF. The primary problem, I believe, is not the inability to create some of the lesions perfectly, it's the inability to create all of them perfectly, but primarily it's that you can't put them where in every place they're needed, and you can't chase them down. So that these problems of not being able to create lesions where you need to create them can't be overcome by new energy sources alone. There are several options that are available after catheter trigger isolation and catheter ablation failures, including a minimally invasive cryo-Mays 3 procedure with different types of hybrid procedures, and they are all superior to catheter ablation. And finally, patients who are undergoing cardiac surgery and have a history of atrial fib should have their LAA closed at the very minimum. Both AF ablation and LAO contribute to survival. So I guess that the lesson of this paper is that I chickened out, Mark. I didn't put it in there. But nevertheless, I hope that you enjoyed that talk and that there are some questions coming. Thank you.
Thank you very much for the excellent talk. We are collecting some questions here. I have one, all the time it bothered me so much. What is your opinion why the surgeons do not perform ablation concomitant with surgery? I mean, why we are still so far to have all patients during surgery ablated by AFib? I mean, it's the EP fault, is the surgical, I don't know. Because 29% is really less, I mean.
I think it's the fault of the surgeons. It's not the fault of the cardiologists. I think it primarily relates almost to a primeval fact about surgeons. When we do procedures, we like to be able to see the results. We like to be able to, measure the results with numbers and so on and so forth. So there's a clear beginning and a clear end and so on. And electrophysiology just doesn't come natural to surgeons. You can't see it. You can't feel it. All you do is go in allegedly and do this operation that somebody like Mark or I tell them to do, and they do it, and the EKG looks better. That's not exactly instant gratification. And 10-year results are not instant gratification. And unfortunately, I think that the answer to your question is they're simply not interested in it. They're not interested in it. It can't be too hard to learn because too many surgeons have learned it extremely well, improved on it, and done it for years with the same results that I had or anybody else has had.
Thank you so much. I'm asking if there is some question. They're coming.
Thank you, Jim. I felt for a moment, 30 years younger, like a student again, 35 years younger. So thank you for that. Only for this, the meeting was worthwhile coming. For me, I think to follow up on Carlo, I really do believe it's what you say, gratification, but it's also still a lack of understanding what the impact is on the long term of the patient. So we have the tendency to treat what I would call the primary, let's say, pathology of the surgeon, of the patient, like the cabbage, like the valves, and we forget the AFib because it's like a bystander. And we think it's a bystander, and we don't know well enough the importance of the arrhythmia on the long term, quality of life, but also survival. And therefore, if you're in a group like I am, where you work together very close with your EP, you realize that EPs are filling their days just doing AFib. Can you imagine? And because you're doing all these other things, but they are able to fill their days just doing AFib, then it must be important. The amount of investment, the amount of technology into their field is much bigger than in our field, and so it should be important. So I do believe that's important.
And let me ask you, Mark, what do you think surgeons can do to overcome the problem? We're not talking about surgeons competing with electrophysiologists for patients that are standalone patients. We're talking about patients who actually are in the operating room in front of our eyes and hands who have atrial fibrillation, and we choose to ignore it. What else is there for them? What do we need to do to correct that?
Well, honestly, I think we certainly the people following us, let's call the TikTok generation. We need a simplified procedure, which is easy to learn and which is not you can change quickly from one to another. Let's say it like this, and it's a bit what you promote also. I mean, you have the MACE procedure, but you have also the possibility to do an epicardial box lesion with an appendage closure, just to make it simpler in the beginning, and then while gaining knowledge and by improving your technique, then you grow into a MACE procedure. I think that is for me the solution.
Yeah, I do too, but that's going to take another 37 years, right?
Well, I'm here. I'll help you.
We will be there. Thank you so much, Jim. Unfortunately, we are running a little bit late. Jim, thank you so much. I think we can give a standing ovation to Professor Cox for this beautiful presentation.
Okay, thank you, Carlo. Thank you for the invitation.